Hi everyone, it's a pleasure to be presenting our study in this workshop. My name is Natalia Ransolin. I am a PhD student of Civil Engineering at URGS in southern Brazil. I will present a systematic literature review on how the evidence-based design is addressing the complexity of healthcare systems. This work is being conducted with Carolina Zani, Professors Tarcísio Saurin, Carlos Formoso, and Francis Rapport. To contextualize this work, it's important noting we are adopting the view of complex socio-technical systems to characterize healthcare services. This approach considers a large and diverse amount of elements interacting, where the variability is inherent. Since there are several stakeholders involved in healthcare sectors, such as patients, family members, staff, managers, public agents, and the population, their needs are of significant amount. It's common to have conflicting requirements. In this sense, the built environment plays a key role in the technical part of complex systems and the social part as well, since it impacts patient and staff outcomes. Actually, there is a field of study called evidence-based design, which originated from evidence-based medicine to support design decision-making. Even though the impact of healthcare built environments are largely studied, they are commonly designed based on the work as imagined by regulations and design guidelines. But in doing so, adjustments to local circumstances are frequent and must be addressed due to changes that arise from the interactions among people in technologies such as the built environment, processes, and outcomes. Requirements are likely to change and be traded off during this design decision making over time. So, healthcare built environments should be designed as an aspect of complex socio-technical systems in order to facilitate daily adjustments. In other words, the resilience performance of those systems. As for the research goal, we want to develop design prescriptions for supporting resilience performance in healthcare workspaces. The theoretical foundations we have been adopting are the 5 guidelines for coping with complexity from Saurin et al., which are 1. Supporting visibility of processes and outcomes, 2. Design slack, 3. Encouraging diversity of perspectives when making decisions, 4. Monitoring and understanding the gap between the work as imagined and the work as done, and last one, monitoring unintended consequences of improvements and changes. The ultimate goal of applying these guidelines is to create an environment that supports resilience. Since in complex socio-technical systems, the variability is part of daily work, resilience is a feature that arises to deal with unexpected events. It could be engineered by the 4 resilience potentials for Honagel, which are respond, monitor, learn, and anticipate. The third string of this study was composed of keywords representing the elements of the research goal, similarly to what is done using PICO, that stands for Population, Intervention, Control, and Outcome. Here, we address the study object as the built environment and related words, context as healthcare systems, approaches such as complexity and resilience, the outcomes as safety, well-being, healing, and the groups of stakeholders focused. We used Prisma method to filter the papers found. Firstly, we have identified more than 2,000 papers from 7 databases plus manual inclusions. A great part of this number was excluded by criteria such as duplication, disciplines unrelated to this work, literature reviews, or proceedings. We included papers based on the reading of title and keywords. In order to maintain only core work, we have searched for keywords in the papers and excluded the ones that don't address complexity, resilience, flexibility, etc. The final number of papers included for full text reading was 39. The word cloud of these 39 full papers is composed mainly of words such as patients, design, nursing, environments, caring, etc. Data were analyzed based on bibliometric information, such as year and country, and what was the research design adopted by the studies, based on a spectrum of research rigor from subjective to objective studies. Multi-methods studies such as shadowing with interviews and observations were adopted by 30 papers. We have also analyzed the focus of the studies regarding the impact of the built environment on users, such as safety, well-being, or efficiency, and also who were the main users involved in the papers included. Some studies have explored built environment design practices to embrace the complexity of healthcare systems, which is interesting to mentioning. For instance, project documentation by recording decision-making processes and requirements management. Mock-up and what-if scenarios can be used to analyze the gap between the work as imagined and work as done, since they provide simulations of work conditions. Some papers also discuss the role of empirical data in validating best design practices, which can be aligned with monitoring unintended consequences of evidence-based design practices. Results of this work focus on design prescriptions that arise from the analysis of papers based on the 5 guidelines, which were the categories of analysis. A design prescription can be defined as a recommendation to be followed in order to achieve an expected outcome. Based on that, 22 design prescriptions were created and distributed in 7 groups. Wayfinding and layout design derived from G1, flexibility, either maintaining or changing the functionality of spaces as sources of design lack. Patient, family, and staff views are aligned with the promotion of a diversity of perspectives. And the build environment as done and the build environment as imagined as the application of the G4 to the build environment context. The last guideline must be considered when the previous design prescriptions are applied. The ultimate goal of the application of these groups is to provide an environment that supports resilience. Wayfinding is related to the ability to provide spatial navigation and zoning, such as visual signage of roads and spaces. Universal accessibility, environmental cues, and positive distractors. One design prescription of this group is to have large windows for exterior and natural light. 26 papers in this review cited wayfinding. The layout design was cited by 31 papers, and it addresses spatial configuration for efficient processes. For instance, the distribution of circulation links and the organization of items in the space, the discussion of visibility against privacy, and having specific areas for socialization, such as day rooms. The flexibility of the build environment maintaining the same functionality of spaces was cited by 19 papers. It embraces the convertibility of spaces to accommodate different patients' acuity levels. For example, double bedrooms with a sliding door in between the beds, for adaptability of large single rooms to small rooms. It's a useful alternative in times of extensive family involvement or terminally ill patients. Also having control of spaces and furniture and expandability by the design of modular rooms that are easily expandable to accommodate more patients and services. 39 papers cited the flexibility of the built environment while changing functionalities of spaces. This group involves multi-purpose resources, dedicated resources for transitions for new spaces, and spaces as barriers for contamination. For instance, to have balconies and exterior doors in isolated rooms where infectious patients and relatives can access without passing through internal corridors. Another point is to anticipate the need for changings by placing additional doors in the isolation rooms in case the exclusive access through the anteroom might be unnecessary if changing the acuity levels for regular patients. Patient and family perspective was cited by 18 papers. This group addresses a welcoming atmosphere to involvement in care and also interaction with staff by having spacious rooms to accommodate family, for example. Also designing supportive spaces for patients and family members to express their feelings. Staff perspective was cited by 17 papers, and it's related to the creation of collaborative workspaces and spaces for resting. Monitoring the gap between the build environment as done and the build environment as imagined was referred by 21 papers. It embraces the design for compatibility between the build environment and the care model. For example, to consider the pros and cons of decentralized versus centralized nursing stations. For care models that require nurses to focus on their own patients, decentralized nursing stations are likely to be better since nurses stay closer to the patients. Also, accounting for anticipated or likely changes in regulations and learning for workarounds. For instance, staff using the ceiling light to block air conditioning when the operation room is too cold suggests a need to change either the layout of the room or the air conditioning system. Pearson correlations were calculated to verify the connections between the groups of design prescriptions. For instance, wayfinding and layout design are indeed correlated since both derived from the first guideline of visibility. The gap between the build environment as done and the build environment as imagined is correlated to staff perspective, since this gap is created and can be monitored by daily work performed by staff members. A conceptual map relating the five guidelines with the groups of design prescriptions was drawn. I will illustrate some connections. Wayfinding and layout design are means to achieve visibility of processes and outcomes, while they help to monitor the need for flexibility by adaptations in the spaces. Wayfinding can also promote patient and family perspective by positive distractors, for instance. And layout design can promote staff perspective by layout configuration for efficient processes. Both can also help monitor the gap between the build environment as done and the build environment as imagined. This monitoring can trigger a comfortable space, addressed by flexibility of space. Then it's important to monitor the unintended consequences of those changes. G5 involves feedback cycles to comply iterative process of improvements. The groups of design prescriptions altogether can help monitor unintended consequences to provide an environment that supports resilience. Finally, the next steps we envision in this work are related to discussing the creation of an environment that supports resilience performance by design and, consequently, an evidence-based design for resilience. A research agenda will be drawn to suggest and guide future and ongoing studies. Thank you all for your attention. Here is my email. Please feel free to contact if you have any question or insight. See you in the workshop.